Bismillahirrahmanirrahim. Assalamu alaikum, everyone. I hope you all must be fine and having a great learning time at the PES DIGICON Sessions 2020 daily. So here I am. I am Dr. Shehla Tabassum. I am working as an endocrinologist at the Shaukat Khanum Memorial Cancer Hospital, Lahore, Pakistan. I will be moderating the session tonight. Tonight, we have another great session on the way, that is diabetes and pregnancy. That is a matter of great significance as the proper management of diabetes during pregnancy results in better outcomes on two fronts, better outcome for the mother and better outcome for the fetus as well. So I'm extremely delighted to have my respected mentor with me as chairperson in this session, that is Dr. Aisha Sheikh. Welcome, madam, on board. She is a consultant endocrinologist and faculty member at the Al Khan University Hospital, Karachi, Pakistan. She is a registered tutor for the postgraduate diabetes and endocrinology diploma at the University of South Wales, UK. Dr. Aisha Sheikh is actively involved in medical education and research and has published several research papers and book chapters and is editor for the book chapter on subfertility. She is joint secretary of the Pakistan Endocrine Society currently. Dr. Aisha Sheikh has keen interest in antenatal diabetes and endocrinology and has played a key role in the development of gestational diabetes guidance from the platform of South Asian Federation of Endocrine Societies, CEFIS. Thank you, Dr. Aisha, for joining us. Now, we are really honored to have a star-studded panel of experts with us who have got vast experience in dealing with diabetes in the pregnant ladies. Our panel includes both the gynecologists and endocrinologists who will share their experiences and give expert advice on the theme of our discussion tonight. Let's go through them one by one. So we are really grateful to have Professor Rubina Sohail with us tonight. Welcome, madam. She is Professor of Ops and Gynae at the Services Institute of Medical Sciences, Lahore. She is immediate past president of the South Asian Federation of Ops and Gynae and has also served on the International Federation of Gynae and Ops Committee on Sexual and Reproductive Health. Dr. Rubina has been widely published, including both the national and the renowned international journals. Then we have the honor of having with us Professor Haleema Yasmin. She is serving as the head of Department of Ops and Gynae at Jinnah Postgraduate Medical Center, Karachi. She holds the post of Secretary General of the Society for Ops and Gynae, Pakistan. She has multiple scholarly publications on Ops and Gynae in reputable national and international journals. Now, from the endocrinology side, we are much grateful to Dr. Musarrat Riaz for joining us tonight. She is working as consultant endocrinologist at Bakai Institute of Diabetes and Endocrinology, Karachi, Pakistan. She has got vast experience of dealing with diabetic pregnant ladies. She is also a well-published researcher in the field of diabetes and has a long list of publications to her credit. Then we are much obliged to Professor Shabeen Masood for joining us tonight. She is the head of Department of Ops and Gynae at the ISRA Medical University, Karachi, Pakistan. Her area of special interest is diabetes and pregnancy. She has about 30 original research papers published in national and international journals. She is also the visiting consultant and the joint secretary at Diabetic Association of Pakistan WHO Collaborating Center. She is executive member of Diabetes in Asia Study Group. Currently, she is heading projects on gestational diabetes mellitus prevention and control programs of Pakistan, funded by the World Diabetes Foundation, Denmark. Last but not the least, we have another shining star from the field of maternal medicine among us, Dr. Lumaan Sheikh. She is Associate Professor and Consultant Maternal Medicine Chairperson and Service Line Chief of the Department of Ops and Gynae at Al Khan University Hospital, Karachi, Pakistan. As she has a huge experience of dealing with the high-risk diabetic pregnancies, so we will be glad to have her on board with us tonight. Welcome everyone with us. So starting the session tonight, we are delighted to have Professor Ronald as our first speaker. He is head of the Division of Endocrinology and Diabetes, Department of Medicine and Therapeutics, Chinese University of Hong Kong, China. His chief research area of interest is epidemiology and genetics of diabetes and its complication, gestational diabetes, polycystic ovary syndrome, and the developmental origins of diabetes. He has got more than 30 research articles in international peer-reviewed journals. His talk will be centered on hyperglycemia in pregnancy, antenatal, and the long term. So, Professor Ronald, welcome, and kindly start sharing your slides, sir.
Thank you very much, Chairperson, for the very kind introduction. And thank you for the organizers for the very kind invitation to join you this evening. So I've been asked to talk about hyperglycemia in pregnancy, in particular focusing on the antenatal and long-term aspects. So what I'll try to do over the next 20 minutes is give a brief overview of different aspects of hyperglycemia in pregnancy, in particular focusing on the short-term consequences as well as the long-term impact, in particular for the offspring. I want to highlight some of the important intergenerational effects and the vicious cycle associated with maternal hyperglycemia, and highlight perhaps as a community what we need to do about it. Here in Asia, in particular, we've actually just in World Diabetes Day today, in Asia, we really need no reminding of the important epidemic of diabetes with its epicenter really here in Asia Pacific region. We can see that from different national surveys that the prevalence of diabetes has really gone up significantly over the last 2 decades, where in some parts of Asia, 1 in 5 individuals actually has diabetes. In terms of thinking about hyperglycemia and the burden of hyperglycemia in pregnancy, this is taken from the FIGO gestational diabetes guidelines, and we need to think more broadly about hyperglycemia in pregnancy, where it actually consists of both diabetes in pregnancy as well as pure gestational diabetes that occurs later on in pregnancy, typically 24 weeks onwards. Diabetes in pregnancy can present in several ways, including undiagnosed diabetes that's previously present but undiagnosed and present for the first time in pregnancy, and this could take various forms. So together, this makes up the burden of hyperglycemia in pregnancy, which according to the IDF is estimated to affect close to 130 million births every year. In terms of global prevalence, it's estimated that about 16% of births globally are affected by hyperglycemia, and that the vast majority, about 84%, are due to GDM, which means that the remaining 16% are roughly made up of equal proportion of either other forms of diabetes that are first detected in pregnancy, as well as diabetes that's already present in prior to pregnancy, so i.e. individuals with type 1 or type 2 diabetes who then develop pregnancy. In terms of the overall burden of hyperglycemia in pregnancy, as I mentioned, this could be due to diabetes occurring in pregnancy, as well as gestational diabetes. And for diabetes in pregnancy, it could consist of either diabetes that's diagnosed before the start of pregnancy, so someone who's already known to have either type 1, type 2 diabetes or other forms of diabetes, or that it is actually first recognized during pregnancy. And of course, that could also be due to type 1 or type 2 diabetes. This issue of pre-existing diabetes is increasingly important in the Asia-Pacific region. That is because we're seeing increasing number of young individuals with diabetes. So in a survey of around 40,000 patients with young onset type 2 diabetes, so they recognize they have type 2 diabetes, and they are asked to recall the age at which they're first diagnosed with diabetes. You can see that in this multi-center study that was conducted by Professor Juliana Chan and using our joint Asia Diabetes Evaluation Program, in fact, 1 in 5 of patients with type 2 diabetes in Asia are actually diagnosed before the age of 40. So we really have quite a lot of reproductive age men and women who already have type 2 diabetes by the time they're at reproductive age. So that is increasing and contributing to the burden of hyperglycemia complicating pregnancy. In terms of individuals who already have diabetes, of course, the risks are well recognized. These include maternal risks, including an increased risk of pregnancy-induced hypertension, preeclampsia, other pregnancy complication, polyhydramnios, difficult labor, obstructive labor, uterine atonia, and increased risk of postpartum hemorrhage, increased risk of infections, and of course, worsening of diabetic retinopathy during pregnancy. In addition, there are also long-term risks to the mother, diabetes being well recognized to be associated with increased risk of cardiovascular disease later on in life. In terms of fetal risk for pre-existing diabetes, again, there are significant risks, including congenital malformation, shoulder dystocia due to large baby, neonatal hyperglycemia, and respiratory distress. And I will talk more about long-term risk, but individuals who are born to mothers with pre-existing diabetes have high risk of diabetes and obesity later on in life. Of course, much of this data first came from the Pygmy Indian population, where there is a large proportion of young onset diabetes, and it was found that individuals born to mothers who have young onset diabetes, in fact, also have high risk of diabetes later on in life. And this risk is present only if they're born to mothers with young onset diabetes as opposed to fathers with young onset diabetes. The risk is higher amongst mothers, and the risk is higher amongst offspring who are born after the mother has developed diabetes. But there's similar data from other parts of the world. I've included here data from Denmark, which also show the risk of diabetes and prediabetes is significantly higher in offspring born to mothers with diabetes. If we want to think about the long-term effects of hyperglycemia, it's important to actually go back to the original idea actually put forward by Frankel in his Benting lecture, that in fact, gestational diabetes, if it was purely gestational diabetes occurring late in gestation, really would predominantly hit on the programming of metabolic pathways. This is different to offspring born to mothers with pre-existing diabetes, who in fact have hyperglycemia throughout gestation, and therefore the hyperglycemia will impact on organogenesis, behavioral pathway, as well as metabolic pathway, and in these, this is very much mimics what we see from epidemiological observations. So in terms of diagnosing gestational diabetes, I think there's been a lot of debate, but that has more or less now been settled. And it's good that there's now consensus among WHO, IDPSG criteria now adopted by WHO as well as FIGO, that the IDPSG criteria has now been adopted, where at 24 to 28 weeks, gestational diabetes is diagnosed by a fasting glucose of 5.1 or above, 1 hour of 10.0 or above, and 2 hours of 8.5 or above. But in addition, if there is abnormal glucose that is picked up earlier on in pregnancy with fasting glucose of 7 or above, 2-hour glucose of 11.1 or above, then that is suggestive of pre-existing diabetes. In the FIGO guidelines, it actually has provided guidance about detecting hyperglycemia at different stages in pregnancy. As mentioned before, in all settings, including low resource setting and high resource setting, all women really should undergo universal screening at 24 to 28 weeks. But in addition, when resources allow, women at first booking should also be screened for pre-existing diabetes, either using fasting glucose, random blood glucose, HbA1c, to see if there is presence of pre-existing diabetes. If that is normal, then at 24 to 28 weeks, a 75-gram OGTT should be performed with the purpose of screening for gestational diabetes. There are specific recommendations given in different settings if needed to try to simplify some of the screening in the guidelines, and different regions have adopted different modifications in order to screen for gestational diabetes. But focusing on gestational diabetes, given that this is the major burden of hyperglycemia in pregnancy, the rates are really increasing at alarming rate. And this is partly also due to the modification of the criteria and now adoption of the IDPSG criteria, which in general would increase prevalence of GDM in most places. This is data from Tianjin in China, where they have been doing a universal screening as part of a Tianjin GDM screening program. And you can see that over the last 10 years, there has been a steady rise shown in red in terms of the GDM prevalence, which is approaching around 9%. In Korea, where they also have been doing fairly good universal screening, again, rates of GDM has gone up quite rapidly over the last 10 years. So to understand the long-term impacts of gestational diabetes or pre-existing diabetes, again, if we go back to the principles and the original studies by Peterson, Frankel, and also Dr. Metzger, then it's important to realize that the placenta is actually only a passive barrier where nutrients go from the mother to the fetus actually down concentration gradient. This is particularly true for glucose, amino acids, and also some of the lipids. As a result, when there is presence of maternal hyperglycemia as in pre-existing diabetes or in mothers with gestational diabetes, then glucose would diffuse down this concentration gradient, stimulate insulin production, and as well as growth, leading to macrosomia. But in addition, other nutrients that are present in maternal hyperglycemia obesity, for example, amino acids and fatty acid, also contribute to this in utero overnutrition and contribute to the phenotype, which we'll talk about later. In terms of some of the consequences of intrauterine exposure to maternal hyperglycemia, and this is true for both pre-existing diabetes as well as gestational diabetes, this oversupply of substrate will stimulate fetal hyperinsulinemia, increase substrate uptake, and leading to macrosomia and some of the other complications. But in addition, this is also leading to some of the other metabolic effects, including hypoxia, polycythemia, and some of the birth complication, and also the increased risk of respiratory distress. If we think about gestational diabetes, we often think about the glucose cutoff, but it is important to realize that in particular with regard to the metabolic defect, there is really no real threshold. I plotted here data from the original HARPO study, which of course examined the glucose criteria that would lead to increased risk of perinatal complication. When we plot the maternal glucose either as fasting glucose, 1 hour and 2 hour glucose in the 7 different categories, and if one looks at skin fold thickness as a measure of adiposity at birth, one can appreciate that regardless of whether we're looking at fasting 1 hour or 2 hour glucose, in fact, the relationship between maternal hyperglycemia and adiposity in offspring is actually continuous. So the thresholds are rather arbitrary when we think about metabolic risk. When we actually followed GDM offspring and mothers in our local study to look at what happens to GDM mothers and offspring, this is actually using the old WHO 1998 criteria, we see a significant proportion that actually progressed with impaired glucose tolerance and diabetes. At 22 years, about half of them have developed some degree of glucose intolerance in the mothers. And what we noted was in the children, even at the age of 8, children born to mothers with gestational diabetes, in fact, have significantly higher blood pressure and lower HDL, suggesting that they already are metabolically more adverse compared with children born to mothers with normal glucose tolerance. To try to investigate and understand this further, we recently completed a long-term follow-up of children and mothers from the HARPO study, which of course originally was a multi-center study around 15 centers around the world. In Hong Kong, we recruited around 1,600 women, and over the last few years, we tried to follow up both the mother and children at around 7 years post-pregnancy and did detailed metabolic evaluation. What we found was that the children, even at 7 years, were significantly had significantly higher BMI. They were more likely to be overweight, and they also had significantly higher 30-minute glucose, 60-minute glucose, with a higher proportion that are already showing dysglycemia. And again, like our earlier study, they show higher systolic blood pressure. So the risk of GDM was in fact associated, the offspring, even at 7 years, with untreated GDM diagnosed according to WHO 2013 criteria. They already had approximately 3-fold higher risk of abnormal glucose tolerance, and also, as shown here, had approximately 60% higher risk of overweight and obesity, and suggesting that even after adjusting for maternal exposures, including maternal BMI, that GDM is significantly associated with increased risk of adiposity in the offspring. In fact, the HARPO study later on went on to, with 10 of the centers out of 15, including our center in Hong Kong, went on to follow up more of the children and mothers from the original HARPO study, this time at 11 years. And this included about 4,700 mothers and children. What was found was that, again, as expected, the mothers, they have a 7-fold risk of progressing to type 2 diabetes compared with mothers who did not have GDM during pregnancy. But importantly, again, in the children who were exposed to GDM as defined now by the WHO 2013 criteria, that the children had approximately 50% high risk of overweight and obesity. And even after adjusting for maternal BMI, there is increased risk of childhood obesity. So these are the different statistical model in terms of overweight and obesity. In a fully adjusted model, including maternal BMI, there was a borderline increase of 20% risk of overweight and obesity. But GDM exposure was independently associated with 58% increased risk of childhood obesity. And these are different measures of increased adiposity in the offspring. And again, GDM is associated with increased risk of childhood obesity. Perhaps the most impressive finding I find myself is when they actually look at the relationship between maternal glucose during pregnancy and the child's glucose during the OGTT at 11 years. Look at the relationship between maternal glucose either in fasting 1 hour or 2 hour in red, green, and blue. You can see almost a linear relationship between the maternal glucose during pregnancy 11 years earlier and the child's glucose levels during the OGTT 11 years later. And this is true for fasting glucose, 30-minute glucose, 1 hour glucose, and 2 hour glucose, suggesting there's really a very high correlation between maternal glucose level during pregnancy and the offspring's glucose level 11 years later. So what this highlights is really that the exposure to maternal hyperglycemia and GDM and the in utero overnutrition really programs the risk of diabetes and metabolic risk in the offspring. And this sets up a vicious cycle, and the child really reflects the hyperglycemia levels during pregnancy. Another way to think of it in terms of a life course approach is that GDM, in fact, identify a woman who is on a high-risk trajectory for non-communicable disease and diabetes during her life, but that this risk is actually also transmitted to the next generation, where the child also starts life on a high-risk trajectory compared with the counterparts born to mothers without gestational diabetes or hyperglycemia. We focus mainly on talking about GDM, but it's important to remember that maternal obesity is another important exposure. This is data again from the Harpo study looking at the effects of maternal glucose versus the effect of maternal obesity. You can see that going down with increasing maternal obesity, there is increased risk of excess adiposity for the offspring at birth, but adding high glucose effect with obesity effect, this risk is actually substantially increased. There's also then the added issue of gestational weight gain, which I've not had time to go into, but the three, maternal obesity, gestational weight gain, and GDM, all act synergistically to further increase risk. So what can we do to try to reduce this risk and potential intergeneration effect? Can we reduce GDM? The answer is yes and no, because unfortunately, most studies, including large-scale studies such as Upbeat, Limit, and other trials that have tried to reduce the risk of GDM in overweight women using lifestyle intervention have all met with limited success. In a meta-analysis looking at some of the studies, one can see that really only lifestyle intervention implemented early before the 15-week collectively has a modest effect in reducing GDM. So intervening during pregnancy is perhaps too little too late. There are studies to look at trying to intervene post-pregnancy to help the women lose weight, improve their metabolic profile, and hopefully avoid further metabolic complication in later life or later pregnancy. And there are a number of studies that have successfully shown this. This is one example from California, cluster randomized trial, 2,000 women with GDM randomized into different clusters with intervention, giving gestation weight gain recommendation, support through telephone to try to help them to reduce weight post-pregnancy with successful postpartum weight loss, especially if they are compliant with the sessions to actually go through the intervention. What about lifestyle intervention to prevent progression from GDM to diabetes? We know that GDM women have 7-fold high risk of progressing to diabetes, and lifestyle intervention afterwards to prevent diabetes progression is also something very worthwhile. Unfortunately, there are only a few randomized clinical trials that have really examined this. And in this meta-analysis, we found that really only a small number of studies, but mainly those that are implemented and initiated within 1 year after pregnancy, there is a modest effect in reducing subsequent incident diabetes. So a lot more work still needs to be done in this area. So in a summary, sort of thinking about the high risk imposed by hyperglycemia in pregnancy and its long-term effects, in particular on the next generation, we really need to think about intervening through the different life course stages in pregnancy, in pre-conceptual period, in the postnatal period, in particular, encouraging breastfeeding, which reduces the progression to diabetes, also increasing physical activity and getting them to lose weight after the pregnancy, and of course, different practices to encourage optimal fetal health. I just want to highlight that actually just 2 hours ago, we launched the Lancet Commission on Diabetes, and in fact, we're able to incorporate, this include many different aspects of closing the gap on diabetes care, but including highlighting the importance of this intergeneral cycle and trying to highlight pregnancy as an important window for health actions to try to target diabetes and NCD. And we're pleased that we managed to get this important message into the Lancet Commission on Diabetes. So in summary, the risk of diabetes and other NCD begins in the womb. Maternal hyperglycemia is associated with increased diabetes and obesity in the offspring. GDM, maternal diabetes and obesity perpetuate this vicious cycle of diabetes begetting diabetes, and really early identification intervention is important and provides a unique opportunity for NCD prevention in the women. And with that, I would like to thank you for your kind attention and thanks many of our colleagues, in particular Professor Wing Hong Tam, our obstetrician, our hospital, who I've been fortunate to work together closely over the last 15 years. And with that, thank you again for your kind attention. I'll be happy to take questions later.
Thank you, Professor Ronald, for such an elaborative talk on the subject. So as we have back-to-back sessions, so we will move to the next section. Next in the row, we have Dr. Sadia Salman as a speaker with us. She is the Assistant Professor in Endocrinology Department, Jinnah Hospital, Lahore. Dr. Sadia is a competent endocrinologist who, while serving in a public sector hospital, is catering to a large population of pregnant ladies with diabetes. Her talk will be centered on preconception care of a woman with diabetes. Over to you, Dr. Sadia.
Thank you, Shehla, for such a nice introduction. And I must say thanks to Professor Ronald for such a great talk. He has made things easy for me. Till now, we have discussed what happened when a lady is pregnant and has hyperglycemia. I will start from a back step. If a lady comes to you, he's diabetic and planning to conceive, so what steps you will take? That is preconception care of a woman with diabetes. Become pregnant is a dream of every woman. From your brain, a 35-year-old lady, known type 2 diabetics for last 3 years and hypertensive for last 2 years, come to your clinic and she's on oral medication for both. She's planning a pregnancy and she has a history of bad pregnancy outcome for which she is worried now. So what steps you will take? Think in your brain and we will answer this question in the last slide. What management steps you will take before allowing her to become pregnant? So by the end of session, you will well aware of the prevalence of pregestational diabetes, risk counseling, evaluation and management of hyperglycemia, and evaluation and management of complications of diabetes. The term pregestational diabetes, it refers primarily to the type 1 or type 2 diabetes mellitus diagnosed prior to a woman's pregnancy. And it complicates 1 to 2% of all pregnancies, and it accounts for 13 to 21% of diabetes in pregnancy. Obviously, the rest are GDM. The proportion of a pregnant patient with type 1 or type 2 diabetes, it reflects the prevalence of these disorders in the specific population. And it is like if in Pakistan, type 1 diabetes prevalence is less than 2%, and about the type 2, we say it's roughly 11 to 13%. And there is significantly elevated risk of adverse maternal and fetal outcomes. So, preconception counseling, it should be focused on the potential effects of diabetes and their medication on maternal and fetal outcomes, and the potential effect of pregnancy on their diabetes control and any existing complication. And preconception care, basically it is the hyperglycemia which is the driving force, and we have to inform the lady about the hyperglycemia and its dreadful complications to the mother and to the fetus as well. The key concepts will be patient education, glycemic control, proficient diabetes self-care, medical optimization of pre-existing complications, and comorbidities associated with diabetes. Patient education is a very important step in management of diabetes. It should be comprehensive and ongoing education for shared decision making about the management, goals, medication changes, and for helping patients to meet the considerable demands of self-care and psychological well-being, especially if like in my scenario, if the lady has a previous bad outcome of the pregnancy, then psychologically well-being will be affected. So it should be a patient-centered approach. Risk counseling is a very important step. Before planning a pregnancy involves discussion of fetal, neonatal, obstetric, and maternal adverse outcome. Risks are more with the risk with type 1 and type 2 diabetes are almost comparable. Although the type 1 diabetes, the diabetes age is prolonged and the chances of complication at that time is high. But for the type 2 diabetics, they are usually obese patient and they are usually the age at the time of pregnancy is more as compared to type 1. So risks are almost equal. So in risk complications, in risk counseling, we will tell about the maternal complications. In type 1 diabetics, especially if there's pre-gestational microvascular complication, they can worsen during the pregnancy, and there is high risk of developing severe hyperglycemia and diabetic ketoacidosis. And microvascular complication, if they are already present, they will affect the fetal growth and their chances of small for gestational age or fetal growth restrictions. And ranges in severity about the fetal and neonatal risk, they vary from very mild to large for gestational age to a lethal one with the major congenital anomalies. And the risk of this complication is directly related to the glycemic control throughout the pregnancy. The overall risk of congenital malformation is consistently reported to be 2 to 4 times higher in diabetic mothers, and it is related to the degree of hyperglycemia in the periconception period. Type 1 diabetes ranges from 2.9 to 7.5% as compared with the higher, roughly comparable 2.1 to 13% in the woman with diabetes type 2. The periconception hyperglycemia is associated with the higher end of the ranges. Diabetic embryopathy will lead to congenital heart diseases, the most common congenital anomaly, and it is 35 to 40%, which include the tetralogy of Fallot, septal defects, and transposition of great vessels. Even central nervous system defect is the second most common anomaly, and then defects in the urogenital system, and in the end, sacral agenesis, caudal dysplasia, they are highly associated with the maternal diabetes. And these are some pictures of the CNS anomalies. And now coming to a very important, this is the progression of microvascular disease. It is related to the duration of diabetes and pre-pregnancy glycemic control. Pregnancy alone is not a risk factor for the development of these complications. But if the complications are already present, then pregnancy can exacerbate the pre-existing microvascular diseases. And it depends upon the type of complication which is present and the extent of the complication. So if I will talk about the diabetic retinopathy, the majority of women will not experience any clinically important worsening of retinopathy during or following the pregnancy. But for the women that have proliferative retinopathy in the preconception time, there may be a transient worsening because of the tight glycemic control and because of the volume changes during the pregnancy and the hormonal changes, and it can later on be reversed. But for a small subset of the women with severe pre-gestational retinopathy, visual changes may persist post-delivery. And women with severe proliferative retinopathy or with macular edema may experience persistent or even further progression of retinopathy post-pregnancy. Now, coming to diabetic kidney disease, if the patient previously, before pregnancy, she has a normal albumin excretion and normal renal function test, then they are at a low risk. But if there is a moderately increased albumin urea and normal kidney function, there may be a transient increase in the albumin urea. But women who have already poorly controlled hypertension or reduced GFR and heavy proteinuria, the risk of end-stage kidney disease during pregnancy, it can increase. 40% of the women with serum creatinine of more than 3 or creatinine clearance of less than 50 will develop permanent worsening of the renal function with pregnancy. As far as macrovascular diseases are concerned, there's again increased risk of macrovascular diseases, including the strokes, including the myocardial infarctions, and microvascular cardiac diseases, including cardiac autonomic neuropathy. The risk is related to both to diabetes and the presence of other cardiovascular and renal risk factors. Pregnancy-related volume expansion may unmask any underlying cardiac disease, for example, asymptomatic diastolic dysfunction. Peripheral and autonomic neuropathy, if it is already present, pregnancy will not start a new one, but if it is already present, then it can worsen during the pregnancy, especially in the cases of gastroparesis. The hyperemesis gravidarum will mix with that, and control is difficult in pregnancy. So it have to be decide first what complications are present in the pregnancy. So in the later on, we should know about these things. Decay risk is more diabetic ketoacidosis, and it occurs at a lower levels of glycemia even, and mortality during pregnancy is very high. Now, this was all about the risk counseling. Now, how to manage these patients? Risk counseling, this step we already done. It keeps blood glucose control with A1C in the normal range, and explaining that preconception glucose control is important to prevent diabetic embryopathy and adjusting the medications. So what are our glycemic control targets? Before meal capillary blood glucose concentration, it should be between 80 to 110, and 2 hours postprandial glucose concentration, it should be less than 155. And A1C should be less than 6.5%, and we can go even below this. It should be, if patient doesn't develop hypoglycemia, it can be less than 6% even. So as tight targets will be there, there will be less chances of diabetic embryopathy, less chances of congenital malformations. Women with diabetes should be encouraged to allow minimums of 6 months to achieve optimal glucose control before trying to conceive if glucose levels are not already well controlled. So what is the drug? It's like in my scenario, I was saying that patient was on oral anti-diabetic drugs. So best to start with the insulin. Insulin remains the standard drug for glucose management during pregnancy and should start it prior to conception. Insulins which are safe with a good safety profile, which are the old insulins, NPH and regular one, and the newer one are Lispro, Aspart, and Detimer insulin. They have very well proven studies and safety data to use in the pregnancy. Avoid use of pre-mixed insulins, and if a woman is considering switching to insulin, prompt therapy should be done before conception, insulin pump. And women on pre-conception insulin pumps, they should continue with the same things. Limited data suggesting that metformin and glyburide are effective and safe in the management of gestational diabetes, but data is limited and long-term effects are still not known. So it is better with any oral hypoglycemic drug, we should better to switch to insulin. Hypoglycemia risk is very high in pregnancy, so reinforcement of hypoglycemia management is particularly important in pre-pregnancy time. It is more likely to occur in women with type 1 diabetes. Tell the signs and symptoms of hypoglycemia to the woman and tell action that patient can take if hypoglycemia develops. Like she can carry a snacks all the time, and if a patient begins to experience hypoglycemia when tightening glucose control, give a prescription for glucagon and teach how to use it. Diet is a very important step. Managing all the diabetes mellitus, we prefer diet to that there should be a registered dietitian, and it is really helpful for women with diabetes who are planning pregnancy. Developing a food plan of meals and snacks help the woman to reduce glucose fluctuation and manage fluctuation that can occur. So wait, as Professor Ronald told about the obesity and its impact on the diabetes and the long-term impacts, and he said that during if the changes are during pregnancy, that will not help, but pre-pregnancy weight loss is important. Obviously, it will improve all the pre-pregnancy pregnancy complications as well. Exercise in all the adults with diabetes, the regular exercise is important to improve everything about the glycemia, the weight, and the other cardiovascular risk factors. Supplementation, as I talked, that neural tube defects are very common in diabetics mothers. So American Diabetic Association recommend folic acid 400 microgram per day, and it should be started when the woman started to plan pregnancy. And there are certain societies who say the folic acid even in the more higher doses. There's a definite role in iron supplementation, and when a woman starts planning a pregnancy and during pregnancy, 150 microgram of iodine should be added. Blood pressure control, like in my case scenario, that lady was on antihypertensive drugs. So ACE and ARBs, both they are contraindicated in pregnancies. They should be switched to any antihypertensive that is safe in the pregnancy. Mostly we use it labetalol or long-acting calcium channel blocker. Lipid control, if the patient is taking statin, it should be stopped. Statins are contraindicated in pregnancy because of the limited and contradictory data. Rather, I see a paper that they are still working on the role of statin in preeclampsia, but till that it is contraindicated. So before patient, whenever plan pregnancy, we have to stop the statins. So now evaluation for the complication, we talked about the glycemic control. A1C should be in the target range and get an RFTs and calculate GFR. LFTs should be done and TSH, and then again urine albumin to creatinine ratio or a sport urine or 24-hour urinary traction for protein is very important at a basal level before pregnancy, and fundoscopy. If patient has a diabetic kidney disease, then the risk of permanent loss of renal function is significant if the patient has uncontrolled hypertension and baseline serum creatinine is more than 1.5 milligram per deciliter, and if the patient has proteinuria of more than 3 grams. So if the patient is like that, then for this, you have to refer the patient to a nephrologist who is already dealing the patients which are with kidney disease and planning a pregnancy. And the risk and consequence of the deterioration of renal function should be clearly informed to the patient. And we should weigh the risk versus the desire of patient to become pregnant. As I already told, ACE and ARBs are contraindicated in pregnancy, and the control of hypertension with medication that are safe in pregnancy should be used. If the patient has retinopathy, it can worsen during pregnancy, as I already mentioned, that proliferative retinopathy, and that should be established. A fundus dilated eye exam should be there, and that should be established that which type of retinopathy is there. And if the patient has severe proliferative retinopathy, then she should be referred to a ophthalmologist for the treatment before pregnancy. And because the exacerbation of retinopathy can occur with the rapid control of glucose, so improvement in glucose control should be made gradually over the months prior to a pregnancy when possible. Women with type 1 or type 2 diabetes of long duration may have a cardiovascular disease. Extended evaluation should be based on the patient's history and examination, and baseline ECG should be done. Especially for every woman who is equal or more than 35 years of age, and if there is significant history or examinations which lead towards underlying cardiac problem, then we can have a stress ECG or echocardiography prior to pregnancy. Type 1 diabetics, it is recommended to check TSH level, and if it is on the lower side, start with the levothyroxine, and the TSH level should be less than 2.5 before we allow a woman to become pregnant. And the American Diabetic Association also recommend checking the TSH level prior to pregnancy in women even with type 2 diabetes. So till now we have discussed many things. So it should be a planned pregnancy. Till things are under control, don't go for a pregnancy. So contraception is very important. Family planning with use of effective contraception until glucose control is achieved. Estrogen, progesterone, and progesterone only contraceptive are safe in with type 1 and type 2 diabetics, but women who have developed microvascular complications or macrovascular complication and diabetes duration is long, then estrogen is not a good choice. For this, we can go with only progestin pill, or we can go with the IUD, which are preferable with the copper releasing. Consideration of potential side effects of contraceptive agents should be weighed against the risk of an unplanned pregnancy. And there should be involvement of a multidisciplinary program. Obstetrician, endocrinologist, dietitian, and diabetes educator should be involved. Now, here comes the end. So what is the take-home message considering my scenario in the beginning? pregnancy of a diabetic patient should be planned. Glycemic control, as I mentioned, the target levels, hemoglobin A1C should be less than 6.5%, and insulin remains the first number one choice of therapy. The baseline complication assessment prior to pregnancy, kidney, cardiac status, dilated eye exam, and management of complication before pregnancy, and weighing the risk of a pregnancy to their health versus the desire for childbearing. So women with pre-pregnancy diabetes should plan their pregnancies to optimize the likelihood for a healthy pregnancy, both for the mother and the baby. Thank you.
Thank you so much, Dr. Sadia. Well, it was a very huge topic, and hats off to you that you have covered it within a very short time, very precisely. So next in our talks, we welcome Dr. Usha Sriram as our next speaker. Dr. Usha is a consultant diabetologist and endocrinologist in India and has more than 30 years of experience in this field. Her areas of special interest include gestational diabetes, NCDs in women, women and diabetes, and osteoporosis. It's a huge honor for us to be benefited from her experience in the area of diabetes and pregnancy. She will be delivering a talk on implementing GDM-SERENDIP recommendations in clinical practice, challenges, and solutions.
Thank you so much. Thank you so much. And I have to thank Aisha for this very kind invitation. And I'm thrilled to be speaking on this topic because it's something closest to my heart and something very important. I'll just share my slides right now. So first, I'm very honored to be part of the SAFE's GDM guidelines. Couple of things really made SAFE's think of GDM as a top priority and addressing it and developing the guidelines. So one is, as Professor Ma has very beautifully outlined in his talk, the consequences of to the mother, to the baby, short term, long term, in when a woman has hyperglycemia in pregnancy. So that was one really important thing, and I've just listed all of those complications. And the other real important reason is in our countries, the 5 countries that form part of SAFE's, we have been seeing an explosion of gestational diabetes in general and gestational diabetes in particular, an explosion of that in the past several years, and we needed to address this urgently and aggressively. So in the second SAFE's meeting in Bangladesh, the Dhaka Declaration was made, where we made it that GDM will be a priority. And in October, we met in Colombo in Sri Lanka and actually formed the guidelines. It was published in the Journal of Pakistan Medical Association in April 2018. And I must say special thanks to Dr. Abbas Raza for authoring this paper. And what I'll do is kind of go through all the recommendations that have been made. So the Dhaka Declaration was to initiate the action plan. And then in phase 2, it was supposed to draft formulation of the action plan and begin the relevant research. And then phase 3 was the implementation, and phase 4 is the final recommendations. So recommendation 1 is defining the problem. And basically, as we have known all these years, onset or first recognition of abnormal glucose tolerance during pregnancy, irrespective of whether it persisted after the delivery. But as Professor Ma again very clearly told us that we now are grappling with these 2 different entities. Is it something that is starting before the pregnancy, and are women walking in with pre-diabetes and the metabolic syndrome, or even frank diabetes, and we are picking it up early in pregnancy? And the true blue gestational diabetes is the one that we pick up later during 24 to 28 weeks. Be that as it may, whatever time we identify any level of glucose intolerance, and the HAPO study has again shown us that there is this linear relationship that we need to address it. And recommendation 2 is about the scope of the problem, and global estimates have shown that in Southeast Asia, it is as much as 23 to 27%. I think the most recent IDF Atlas talks about 27%. In Southeast Asia, complicated by hyperglycemia. And within these, individual countries may show a higher or a lower prevalence. Sorry about that. Can you hear me? Hello?
Yes, we can hear you.
Yes, we can.
Yeah, because suddenly I saw a message that said the host wants to, do something. So that's why I paused for a minute. So can I go to the previous slide, please? I'll go to the previous slide. Okay, not able to go. That's okay. So the recommendation 3 is about risk factors in gestational diabetes. A BMI of more than 23. So as you can see, we are following the Asian BMI cutoff. Age more than 25, first degree relative with diabetes, history of having delivered a baby more than 9 pounds or large for gestational age, or a bad obstetric history. Also just would like to point out that in countries like ours, the upper limit for the weight, 2 standard deviations from normal, is usually around 3.5 kilos and not the 4 or 4.5 that is reported in the literature. Previous history of GDM, an A1C more than 5.7, which will qualify them as pre-diabetes, IGT or IFG, not exercising regularly, family origin with high prevalence of diabetes, hypertension, or therapy for hypertension, HDL below 35, obviously things that qualify for a metabolic syndrome. Here they used a triglyceride of more than 250 as opposed to the 150 that was usually reported for metabolic syndrome. Presence of PCOS, acanthosis nigricans, history of CVD. And then, of course, local research was recommended. Within the recommendation 3, the 3.1 is local research to identify even more specific risk factors. Not able to move the slide. Yeah. So recommendation number 4 is, how do we make the diagnosis? So very clearly, who every pregnant woman, especially in our countries, so we're not going for selective screening, but universal screening. Why? Because we have talked about the consequences of gestational diabetes, and we also know the benefits of treating. And when at first booking, for sure, and again, we have heard very elegant data on how common it is for young people to have diabetes or glucose intolerance in our countries. And again, if the first booking, if it is normal, we have to repeat it at 24 to 28 weeks. And how do we do it? In our countries, all of them have pretty much adopted the 75-gram glucose tolerance, the DIPSI guidelines, or the IADPSG can be followed. A1C is not necessary unless overt diabetes is diagnosed with the 75-gram glucose tolerance test. So administering the 75-gram glucose, fasting or non-fasting, and repeating the test 2 hours later. And if it is 140 or more, it is being called as gestational diabetes. This is the DIPSI guideline, which many countries, including Sri Lanka, India, Pakistan, many follow. And the FIGO guidelines have also said that this can be followed for countries like India. So preconception care was spoken beautifully already. The idea is that it's a paradigm shift in approach. We always thought healthy mother gave birth to a healthy baby. But we know you don't suddenly overnight become a healthy mother. You have to be a healthy girl first. then you become a healthy woman, and only then you can become a healthy mother and then have a healthy baby. So our focus in the SAFE's guidelines about preconception care, and I really appreciate how much effort was put into this aspect of the guideline, was to how to raise the awareness about GDM, to do school, college, workplace level awareness programs, to address professional societies, policymakers, medical professionals, and civil society to be sensitized about GDM prevention. And then, of course, how do we take care of people with pre-gestational diabetes, which was very nicely outlined already. So then came recommendation 6, which is in the management of gestational diabetes, self-monitoring of glucose. So a lot of effort went into how should we recommend self-monitoring of blood glucose, because this is one of the areas where there is a huge gap in our countries. So it should be, when it should be done, pre and 1 or 2 hour post prandial, how many times a day, how often, and definitely before going to bed to prevent nocturnal hypoglycemia. So as you can see that if people were on insulin, the self-monitoring was intensified, and if they were just on a medical nutrition therapy, probably they could get into a less aggressive self-monitoring of blood sugar. The IOM guidelines for gestational weight gain was also recommended in these guidelines, and as you can see, which is based on pre-pregnancy BMI, and it's given both in kilos and in pounds, and many of our countries are following kilos, so we follow that. And before I go to pharmacotherapy, we also addressed in detail nutritional therapy in the SAFE's guidelines, where the goal was to really talk largely about what are the goals of nutritional therapy, which is maintain normoglycemia, make sure the maternal weight gain is optimized, also make sure that we address fetal well-being and maternal well-being, and all of this in a way that is sustainable and approved by the mother and her family, culturally appropriate recommendations, which is a kind of a difficult juggling act to recommend all of these things, which is why a nutritionist assessment and recommendation would be ideal for our patients with gestational diabetes. If a nutritionist is not available, that the physician, the diabetologist, or the OBGYN taking care of the patient would recommend the nutrition guidelines that we have set forth. When it came to pharmacotherapy recommendation, we clearly said that it should be considered if one fails to achieve normoglycemic targets with medical nutrition therapy within a period of 1 to 2 weeks. And we set a target of 1 week if the initial blood glucose levels, when we started the medical nutrition therapy, were already nearing the levels that we would use for starting pharmacotherapy, give the patient the benefit of the doubt for 1 week. If they were doing well at the end of 1 week, and we would continue it for 1 more week. At the end of 2 weeks, if they are within target levels, then we would continue medical nutrition therapy and keep reviewing them with their home glucose monitoring. So the targets that we set for the patients are, as you can see here, the blood glucose, fasting blood sugar was recommended to be kept below 92, a 1 hour value below 140, and a 2 hour value below 120. I just want to clarify here, professional societies have recommended a fasting below 95, 1 hour value below 140, and 2 hour value below 120. And in some of the other societies, like DIPSI in India has recommended 90. So just because there are so many different 90, 92, 95, we decided to go with 92 because that is something that in the fasting sugar of the IAD PSG also they use 92. So just to limit the different numbers that one has to remember. So fasting should be kept below 92. If it's below 90, it will be marvelous. 1 hour value below 140, and many practicing physician, diabetologist, endocrinologist prefer to keep it even below 130 and a 2-hour value below 120. And so pharmacotherapy should be started if target blood glucose was not achieved at any point 1 to 2 weeks on MNT and exercise. And we also have provided an algorithm for when one should start pharmacotherapy. And within the pharmacotherapy, whether we should be using oral hypoglycemic agents like metformin or glyburide or insulin was also clearly laid out in the guidelines. Insulin is the treatment of choice. If patients will not take insulin or cannot take insulin, they were recommended to go on oral hypoglycemic therapy, metformin or glyburide. We have now downgraded glyburide and moved up metformin after the reports of NICU admissions with glyburide. But it looks like maybe by the time we revise these guidelines, we'll go back to insulin therapy as our first, second, and third choice. The recommendation 8 is actually, what do we do throughout the pregnancy? How do we address these women for the different visits? So the visit number 1, patient should be counseled about importance of good glycemic control, taking, of course, a thorough history. And if this is for people, if they have any pre-gestational diabetes, that was taken care of completely differently. And then if they were diagnosed very, very early, and or if their blood sugars were high at the time of first booking and they had overt diabetes, they should be treated like a person who actually has pre-gestational diabetes and carefully look at their anomaly scans and look at fetal echocardiogram if necessary, clearly in people with pre-gestational diabetes. And the high-risk women with type 1 and type 2, where it's recommended to take 75 milligrams of aspirin a day from 12 weeks until the birth of the baby. From 16 weeks, of course, routine clinical laboratory investigation, 20 to 22 weeks, a detailed anomaly scan and a fetal echo, as I had mentioned, and at 28 weeks for fetal growth, amniotic fluid volume, 32 weeks again for fetal growth, amniotic volume, which are all really important, and at 34 weeks, routine care was given. And also counseling about, the mode of delivery, timing of delivery, management of birth, all of them really obstetric indications more than anything else. So typically we would like our babies to be delivered by the beginning of 39 weeks if they have been on insulin or have other complications, but never go beyond 40 weeks in people who are been on a well-controlled on diet. And all these discussions need to happen with the mom clearly before they go into labor, because we all know that once labor and delivery has happened, the pressure on the mother, her workload and her priorities and her everything will change, and she's not going to be thinking about processing all this other information that we are going to be providing. Contraception, follow-up, importance of breastfeeding, initial care of the baby, everything needs to be assessed very, very carefully. And also, one of the important recommendations that SEFI's made is a psychological assessment to detect anxiety, depression, eating disorders, and stress. This was something that everyone brought up and was discussed in detail. Intrapartum management becomes recommendation 9, timing and route of delivery, and then no later than 40 weeks, as I already mentioned. And GDM is not a indication for cesarean section delivery. It's really obstetric indication. And most important point that we wanted to make was that during labor and delivery, the glucose level should be really tightly controlled, contrary to what we would believe that we could take our eye off the ball at that time. The woman has already come up to the labor and delivery. Nothing can go wrong at this point. Really what happens is this is directly correlates with the neonatal hypoglycemia. The higher the maternal glucose, the lower the glucose in the baby. So tight control during labor and delivery was also stressed. Recommendation number 10, monitor blood sugars postpartum, at least one fasting and postprandial. And if it is a woman on insulin, she has to be monitored more frequently, at least for 48 hours. May be able to stop all medicines. Insulin requirements, even in people who have pre-gestational diabetes, will fall dramatically. And contraception advice to be given. This typically happens around 6 to 12 weeks when they come for the postpartum visit. Breastfeeding must be encouraged, not only for all the good things that breastfeeding can do. We also know now that exclusive breastfeeding for the first 6 months, complementary breastfeeding subsequently, at least for a year, decreases the mother's chance of getting type 2 diabetes, dramatically decreases her risk of type 2 diabetes in the future. Must have screening prior to next pregnancy, and statins, ACE, ARB should ideally be withheld even when she is breastfeeding, unless there are specific indications. We also made some child care recommendations, which I think is very important. Documenting the weight and recording any birth defects at birth, monitoring the blood sugars immediately after the first feed and regularly for the first 2 days, and then counseling the parents about the risk of baby of mothers of GDM, healthy lifestyle throughout. We heard the beautiful follow-up of the babies born to mothers with GDM, and also probably communicate with the pediatricians that these are babies of mothers with gestational diabetes, and they need to be followed closely for blood pressure and obesity and glucose intolerance and other complications. Fetal loss of women with GDM. This was our recommendation 12, how emotional and psychological support is very important for these women. And then follow-up glucose tolerance test in 6 to 12 weeks. Really important, even in if they've had a fetal loss. So this is really very critical advice that has been given. I've come to the last recommendation that we made. When challenges or new evidence or need arises, the endocrine society of that country could modify the guidelines that we have set, but we'll have to inform SAFEs about that. So I have kind of telescoped everything that we did over a long period of time and put out the guidelines. I tried to do that in a short time. This is something that I have added on my own, which is what should we do at the time of COVID-19? Just to say that we probably will have to be more pragmatic, limit the contact of the women with the hospital and laboratory, and how can we modify it? Can we use capillary blood glucose? So this is something that I hope to be able to talk to SAFEs very soon about incorporating. In summary, GDM is a top priority for SAFEs. The guidelines have been drafted with input from all the societies and in keeping with the evidence. Detailed recommendations from preconception to early pregnancy to delivery and postpartum has been provided. The guidelines are also in keeping the possible local challenges and potential difficulties or changes that will happen in adaptation. Postpartum follow-up has been emphasized, and adjustments for COVID-19 may be coming soon. Thank you so much again to everyone.
Thank you, Dr. Usha, for going through all the salient features of the safest GDM recommendations. I think this collaborative effort of all the South Asian Endocrine Society is a great milestone, and it will hopefully change the shape of the care of the diabetic pregnancies in the near years. So now I will request Dr. Aisha Sheikh, the chair of this session, to give a brief introduction to the GDM-SERENDIP.
तो मैडम ये वाला एडिटिंग कहाँ से इसको शॉर्ट करना
Yes, madam, you're perfect. Go live.
Bismillahirrahmanirrahim. Thank you, Usha, for setting stage for SAFI's guidance. So, as you mentioned, this was the second biennial summit of SAFI's held at Dhaka in 2015, when the Dhaka Declaration was crafted through discussions held at multiple meetings attended by representatives of all SAFI's countries, which include India, Pakistan, Sri Lanka, Bangladesh, and Nepal. And the Dhaka Declaration actually aimed to bring GDM to the center stage of clinical medicine as well as public health. And the Dhaka Declaration provided guidance for advocacy, research, and guidelines formulation in the field of GDM. And through these activities, Hafiz actually hoped to bring about universal screening, uniformity in diagnosis, optimal management, and regular follow-up of GDM. So this is our GDM SAFI's working group. This was the first meeting held in Colombo in 2015. You can see Dr. Usha standing here, uh, Professor Hajra Mehta, Professor Sarita Bajaj, Faria Afsana, myself, our colleagues from Sri Lanka, Professor Nikhil Tandon, who had a wonderful speech on post-GDM care in the oration of SAFI's symposium, Professor Ali Java, Dr. Abbas Raza, Dr. Faisal Qureshi, Professor A.H. Amir, and over here you can see Dr. Lumaan Sheikh as one of the experts. So this group actually worked for 2 years, and then at the third biennial summit of SAFI's in 2017, held at Lahore, the SAFI's recommendations was launched, later on published, and it was endorsed by South Asian Federation of Obs Gynae, which was holding the office in Pakistan at that time. Professor Rubina Sohail was the president of SAFOG at that stage. So SAPI's guidance was published in JPMA, that is the face of this recommendation. And through the platform of Pakistan Endocrine Society, we have been holding workshops and doing CME seminars and lecture sessions throughout country. But since the prevalence of GDM is rising like anything, this is data from our own institutions at the Khan University Hospital, where you can see that from the over more than a decade, there is an exponential rise in GDM prevalence. So somewhere in 2011 and 12, we started to have universal screening at our institution and utilized IADPST criteria. So you can see that the prevalence has right now around 18 to 19%. And similar prevalences have been shown by our colleagues from Indus Health Network as well. So Pakistan Endocrine Society, under the directives of SAFIS, is now collaborating with Society of Obs Gynae of Pakistan, because we believe that until unless we have the obstetricians working with us, we cannot actually reach across the nation to improve the antenatal care of a woman with diabetes or GDM. So GDM-SERENDIP is actually GDM SAFIS and SOGP recommendations nationwide dissemination, Pakistan. And our PES corporate member, Guests Pharma, has pledged to help Pakistan Endocrine Society through an unrestricted educational grant for next 3 years. So this will include capacity building, which will comprise of CME lecture series, which will cover all aspects of hyperglycemia in pregnancy, including not only the preconception, but long-term care of women and child as well. And the workshops, which will be held in a train-the-trainer format, that will eventually make experts who can then train their people at their own institutions and develop teams that can work together to improve antenatal diabetes care. And this will also include patient and public awareness, like we heard about the preconception role of disseminating awareness in our masses as well, and improving the preconception care of a woman with pre-existing diabetes as well. So GDM Serendip, this is the Pakistan Endocrine Society group, On the left-hand side, you can see, and we have been collaborating with our colleagues from Khan University and Indus Health Network for last many years in terms of antenatal diabetes. And I would like to mention one person who actually deserves a lot of praise and honor for this thing, who had actually played an instrumental role right from the inception of this concept to this stage of GDM-SERENDIP, Dr. Abbas Raza. And this is our colleagues from Society of Obs-Gynae of Pakistan who have kindly joined hands with us to work on GDM and antenatal diabetes care across Pakistan. So this is what we wanted to share with all our colleagues from Pakistan. And you'll be having sessions starting from next year. At least for 3 years, we'll be working on antenatal diabetes from the platform of SAFI's PES and SOGP joining hands, and CATS Pharma will be supporting us in this important venture. Thank you very much.
Thank you, Dr. Aisha, for this brief introduction. And now I hand over the podium to you to involve all the speakers and the panelists and answer to the questions from the participants as well. Thank you.
Okay, thank you very much, Shehla. So, Professor, thank you. Those were really excellent talks. And I would like to hear from Professor Ronald. What is your idea about this early onset GDM? So we know that if a woman already has pre-existing pre-diabetes, and if she gets pregnant and screened in the early gestation, her sugars will show values which will actually be on the levels which are sufficient to make a diagnosis for GDM. And then since we do not have much data on early onset diabetes, what should we do about these women who are early onset GDM, not over diabetes, not having pre-existing diabetes?
So thank you. So you mean that they probably have underlying prediabetes that's not known before, but when they become pregnant at first booking, they have glucose level that actually reach the threshold for diagnosis of diabetes. So fasting glucose over 7, do you mean, or below that threshold?
No, so below that threshold. So levels which will otherwise diagnose GDM, but those are found in the early phases of pregnancy, not at the 24 to 28 weeks. In the early pregnancy, if
so
there
sort
are,
of like fasting glucose over 5.1 and
yes, 5.1 to 6.9.
Yeah, I mean we don't routinely screen for that, of course, and the other thing to notice that glucose level do lower somewhat at early part of pregnancy. So I mean we probably would not start treatment as such, because if they don't achieve the levels diagnostic for diabetes and it's not really levels at for GDM diagnosis, we probably would not commence treatment, but would probably monitor closely, especially for any worsening of the glycemia. I don't know whether any of the other colleagues have any specific advice with regard to this entity.
Okay, so Dr. Usha, would you like to give your comments on these early onset GDM women?
As Professor Ma has said, it's possibly, they are women who have had, I can't think of a scenario where they would walk into a pregnancy and their sugars would be high, except that one, that they already had it before they got pregnant, because typically as soon as people get pregnant, their sugars are actually about 8 milligrams or so lower, and their insulin sensitivity is a little bit better, and they actually don't eat that much because of early nausea and other things. So it's unlikely scenario that someone based, that the pregnancy would cause that. So they're all people who are like walking in to the pregnancy with some degree of glucose intolerance, that and therefore, I mean, I'm just saying that medical nutrition therapy is all that they probably need. We cannot look the other way. At least I don't. Once having seen clearly, the numbers are not normal. Clearly, they're not diabetes, so put them on medical nutrition therapy.
Thank you. But suppose, because we know that the pregnancy targets are like 92 or 95 fasting and 2 hour 120 random. But if the numbers are high, because you'll be monitoring as well. So would you like to read? Because what I understand from Professor David Simmons' work from the Caribbean region, they're actually looking into intervening in these pregnancies and have come up with there's upcoming data on this aspect, because this is something where understanding is still evolving. So early onset GDM, and you're right that these women would be definitely pre-diabetes, pre-conception, but not known to have that. We have got a couple of questions here.
Dr. Aisha, can I make a comment here?
Yes, sure.
See, this early onset GDM is being worked upon, and there is a STRIDE study which has been initiated from India. Dr. V. Mohan is the main principal investigator for this, and still we do not know. Treatment is a separate entity. First, we need to know what should be the levels of diagnosis if we are diagnosing early GDM, and what should be the most appropriate way of diagnosing. What should be the most appropriate screening methodology for the diagnosis of GDM, early GDM, that is in first trimester. So presently we do not know whether to do an TTT, a fasting, an HbA1c. So this has to be known, and we are waiting for the results of the STRIDE study, because the studies that are conducted in India, they are very close to our heart, because most of us, in Pakistan, extrapolate our data from our Indian studies as well. So we are just waiting for the STRIDE results to come out.
Thank you, Professor Shabeen, for your input on this matter. I'm sure GDM is one subject where lots of data and controversy is always there. And I hope in upcoming years with more research, many things would be answered. So Professor Ronald, would you like to comment on your the concept of intergenerational cycle of obesity, and what can we do more? Like in Asia, we know that there's a high risk of all these things happening. So how can we improve care in a manner that we break this cycle of intergenerational obesity and metabolic problems?
Well, I think all the things that we've heard this evening are really vital. The preconception care, trying to optimize glycemic control for women who are planning to get pregnant if they have pre-existing diabetes, trying to screen, universal screening for GDM, trying to pick it up early, trying to treat, even though there isn't much data on treatment of GDM on long-term metabolic outcome in the offspring, but surely that is something that we have to do. I think there's a lot of gap in terms of the postnatal screening, even in Hong Kong, and I know in a lot of other Asian countries, women with GDM, after they've given birth, of course, with lots of things to deal with, often their own health is neglected, and the postnatal OGTT compliance rate is probably around 30% even in Hong Kong. So there's a lot of loss to follow up, and of course, engaging them and trying to empower them is important. We're just finishing a postpartum intervention trial where we've tried to identify women in GDM, trying to get them onto register, and then try to invite them and give them lifestyle intervention to try to start the diabetes prevention sort of soon after pregnancy, essentially. And hopefully that is one approach that will engage the mother and throughout later parts of her life. And of course, being aware that her offspring is also at risk, and therefore empowering mothers to have healthy lifestyle would really have double the benefit in a way. I think the adolescent nutrition is a key aspect, and of course, we're all trying to combat childhood obesity through different ways. So I think really targeting all the stages of the life course using different approach, working with stakeholders, working with government, and as well as doing a lot of public education. We also trying to start a public education program locally. We're just applying for funding to try to engage young women, trying to do school education. I think a lot of the things that Dr. Usha mentioned, sort of all the implementation and trying to do education in schools. I think these are all key aspects that we all need to do to try to address the impacts of GDM at multiple time points. I think GDM is really a very good example of the possibility to address different NCD, not just diabetes, but also cardiovascular disease, also hypertension, by using sort of GDM as the handle or the entry point.
Thank you. So,
Aisha, can I say something?
yes, sure.
I just wanted to ask Professor Ronald, you have a very nice talk. Whenever we are talking about diabetes and pregnancy or GDM for that matter, we always think about obesity and overweight and all these things. But there is so much data that undernutrition is as important. Underweight women are as prone to getting these diabetes and all these IGTs. Would you like to comment on this? And another one, all the guidelines that are available right now for the diagnosis of GDM is based on 75 grams oral OGTT. Now, in so many places like Pakistan, this is a very practical problem. So is there any chance in the near future we can have glucometers or anything less cumbersome being used as a diagnostic modality? Anything in research or anything we might be looking forward to it? Just your comments.
Thank you. Two very important questions. Of course, undernutrition is a very, very important factor in much of Asia. And of course, the seminal work by Dr. Yashnik on sort of the undernutrition cycle feeding to high risk of GDM, and then of course, then starting the other cycle of diabetes begetting diabetes is very, very important work. So certainly I don't mean to underestimate the burden of undernutrition. So I think when we think about optimal nutrition in Asia, really undernutrition as well as overnutrition are just as important. I do want to mention the fact that in our localities, similar to in India and in Pakistan, a lot of our women with GDM are not overweight. So unfortunately, because of the burden of young onset diabetes and maybe also partly genetic factors and also our dietary practices, we do have a lot of women with young GDM who are not overweight. So we have a similar challenge in terms of them having perhaps inherent defects in beta cell function, but also underlying insulin resistance. And we are seeing increasing number of women with PCOS which are undiagnosed. And of course, that's also an important contributor to the epidemic of hyperglycemia in pregnancy. In terms of your other question about how we could do away with OGTT or try to simplify, I think different countries are all trying to find ways to simplify. Indeed, OGTT is cumbersome, it's difficult, it's poorly tolerated by women having the test. And I think for example, in the fecal guidelines, it does cite examples of different countries where they have adopted or have made modifications based on the sort of standard universal screening using 75 gram OGTT, but it's all based on evidence that has been generated in those countries. So I think the important is to try to use other means. I think also ambulatory glucose monitoring is going to be a very interesting way to try to maybe pick up this glycemia early without at different stages of the pregnancy. And I think all these technology, we need to try to evaluate them to try to find more practical and pragmatic ways to pick up this glycemia in pregnancy early in a convenient way. So no, I completely agree. But those data need to be generated in our different communities in order to make it into a practice that the professional societies will adopt.
Thank you.
Thank you very much. I request rest of our panelists to please give their expert comments. Professor Rubina, Sohail, and Professor Haleema, Yasmin, Dr. Lumaan Sheikh.
Do you want me to go first?
Yes, sure. Sure.
Rubina, please.
Okay. I think there are a couple of points which have sort of come up to my mind with your discussion. I think one of the most important things is that women, when they are getting pregnant, there's very little concept of preconception counseling in our country. And though we may be talking about endocrinologists and talking about physicians, but many women do not understand that before they get pregnant, they have to make sure that their HbA1c is within the normal range. So I think that it is very important for us at various forums to talk about the fact that pregnancy has to be planned, especially for women who have got medical disorders. I think this is a very important point, and that has to be highlighted again and again, because we have women coming to us getting pregnant with the HbA1c of 12 or 10, and then it becomes very difficult to manage them. Termination of pregnancy in our country is not a concept which many people would like to adapt, and they would also not understand that with a high HbA1c, they are likely to develop congenital malformation. So this is one issue. The second issue is that in our part of the world, there's this concept of eating for two. And up to date, we have not been able to change that concept for eating for one. So many women are actually becoming diabetic during the pregnancy just because of the fact that they are sedentary and they are overeating. So while I love to hear the talk on undernutrition, but it's a problem of wrong nutrition as well. So even the ones who are poor and who cannot afford food, but they are going to spend money on fast food like McDonald's, and they're going to have cold drinks and things which are actually going to make them diabetic. So when you talked about poor nutrition, I was especially I wanted to listen to this in detail, because poor nutrition does not only mean that they're not eating enough, it also means that they are not eating right. And I think this concept has to be thought of as well. The third thing, when you were talking about the fact that women who get you get a high blood sugar level in the early part of pregnancy, I think many of these women are actually already diabetic, and they were not aware of the fact that they were diabetic, and this is the first time they're diagnosed. And how are we going to manage their diabetes would actually depend on the level of blood sugars, what is the monitoring telling us, and what is the evaluation of their lifestyle and the kind of nutrition that they're taking. And I think many a times modification of nutrition and including physical activity in their daily routines would help us bring the blood sugar down without anything. So I think I'll stop over here. Other people have to say, then I'll come.
Thank you very much. So, Dr. Lumaan, will you like to comment about their questions in the chat box about use of oral agents in pregnancy?
Yeah, I saw. Thank you, Aisha. First of all, I would like to congratulate all the speakers for having such a informative and comprehensive talk, as well as Dr. Rubina Sohail sharing what was just coming out from my heart, Dr. Shabeen for her comments as well. No one can emphasize it more that awareness is the part, and the second thing is the prevention is the part which we all should be focusing on. Unless there is awareness, women will not only women, their families, because in our country, the population, the women are all surrounded by the family members, and there is a strong influence of the family. So I would like to say that prevention is another part where we all should work together together with SOGP and everyone, and come up with some plans. And third thing is involvement of all the healthcare providers who are involved in the obstetric care of pregnant women. Nutrition should remain the main theme for reproductive and maternal health as a part of SDG, and we all should work together on nutrition, which is the most cost-effective and the natural way of preventing it. Now, coming to the part of oral hypoglycemics, I know that insulin, and we all know insulin is the gold standard, but working together, Aisha, myself and you, in our combined maternal diabetic clinic, how we see the acceptability of insulin, the non-compliance of women with insulin, the fear of insulin, and the family pressures for not using the injections of insulin. They may get just lifelong, they will be on lifelong. So oral hypoglycemic agents, the role comes up. We know of the trials and the evidence which is there. Definitely there are long-term studies still needed for the effect of metformin on the baby's development in the long term. But in terms of control and these things, we have seen that despite being insulin the gold standard, metformin is very, very acceptable to women. And so it is overall has a safety profile for the short term, and definitely when the long-term studies will be there, we will be able to see it more. But to be very honest, we are using it because the acceptability is very high, especially in a group where there is a lot of obesity and they develop diabetes. They accept it, and we see a quite good control. Referring to our study of with Dr. Aisha Wali, all 5 campuses of AKU, we had this use of oral hypoglycemics versus insulin. Not to forget the initial MIG trial which was there. I would say that we did have the results which were in favor of metformin as well. I mean, we can use it. And our own experience is that it is more acceptable, so it can be used. So my comment would be to those who are on the chat box and asking about oral hypoglycemic agent. It's only, the literature is only about right now giving evidence on metformin and glyburide. They are not the first line as such, but you need to individualize the cases. Glyburide still data has become a bit cautious about it after the recent some meta-analysis on saying macrosomia, more macrosomia in those babies, and that needs to be seen. But metformin can be used where insulin is not acceptable. You can use it and you can individualize, and many a times a combination in type 2 where then the dose of insulin is less. So less chances of hypoglycemia are seen. So that is how I see it. There was someone who has asked about SGTLs, though I'm not a very expert, but being a maternal medicine consultant, I try to keep myself updated. Still, there is no data on the use of SGTLs. Correct me if I'm wrong, Aisha, on the use of SGTLs in pregnant women. So that cannot be used, except for the 2 oral hypoglycemic.
Yes, these are recent, newer groups, and we do not have any evidence. And unless we have any evidence, we cannot use it in pregnancy. But you are right that metformin, in Pakistan, we use it a lot, not only for GDM, but for type 2s as well. But we individualize the care of the woman. So if a woman is having SGA baby, so this is small for gestational age baby, we tend to stop metformin in them. Similarly, if the pregnancy is complicated by preeclampsia or obstetric cholestasis, we do not use metformin over there. So we closely monitor those women, follow their growth scans, the fetal growth scan, and then use metformin. And we have seen that the insulin resistance part is handled very well. And I can quote the latest study, the MIGHTY trial, which was done on type 2 diabetes women, recently published in Lancet Endocrinology. So I would like to ask, Usha, do you use metformin in India in pregnancy?
In India, yes, but I don't use it. I use insulin as the first choice. And like I said, only in those women, see, anyway, even the MIG used it after 20 weeks. So we are talking only about women after 20, when you're screening them after 24 weeks, it kind of comes to only that group. There's no data for people who are diagnosed early, and we cannot extrapolate findings from PCOS or other things for that group. So I don't use it. So it becomes actually a smaller group. And I also am really concerned about this secular trend we are beginning to see, that the baby weight is coming down. So we don't want that to happen. So that caution needs to be there. So a lot of filters have to be put in. What is the maternal weight? Has she gained enough weight? How is the baby growing? So when you factor all of that in, and finally If they absolutely will not take insulin or cannot take it for some other logistic reasons, then I'm okay with that. But as a, first off, it is convenient. It is easy, definitely, as Madam said, more well accepted by patient and family. But then, of course, anyone will accept a pill better than an injection. But I think with enough counseling and time spent explaining the pros, cons, benefits, most would take the insulin, is what I think. But then, so I don't use it. I use it only in a very, very small group of women, only those who cannot take it.
Can I ask a question?
Can I, sorry, Dr. Rubina.
I just wanted to ask whether any one of you is using long-acting insulin to control diabetes in pregnant women.
Yes,
I'm using Detamir. I'm using Detamir as a basal. I'm also using, of course, as much as possible, short-acting analogs and Detamir or NPH. Use glargine only in pre-gestational diabetes who have been on glargine already, and I don't want to change, and they've come to the pregnancy. If we've had a chance to change them from glargine to Detamir prior to the pregnancy, if they came for preconception care, that would be great. But if they didn't, and if they came just after finding out they're pregnant, then I don't usually change the glargine to another insulin, because I think the Endocrine Society also approves that.
Thank you.
Aisha, can I make a comment here?
Yes.
About this metformin thing, though, as Dr. Usha very nicely said, that a pill is better than an injection. But after this MIG trial, they started a tofu study. That was a 9-year follow-up study in children who were exposed to metformin in intrauterine life. And there are some concerns arising from the use of metformin. So if we are starting metformin, maybe after 20 weeks of gestation, then a little caution is required. Obviously, at this moment, we are very happy with metformin as compared to insulin because of, different reasons. So metformin has to be taken with a pinch of salt as far as the children are concerned. And the tofu study now is giving a 9-year follow-up. Previously, we were looking at 2-year follow-up. Now, the results have come up with a 9-year follow-up. So that has to be taken care of.
Thank you. So, Dr. Sadia, there's one question about regime of insulin given in GDM. So, can you comment on that, Sadia?
Yes. If we start the first time insulin in the pregnancy, and then we can start with the lower units if the readings are near our target. But if the readings are very high, we can start from a high unit as well. But always start from a lower side. You can go with maybe 0.5 unit per kg body weight, and you can divide these doses into a 50% basal and 50% bolus as free meals. But you always check these, obviously, whenever you start first time insulin, then always check the targets, we are achieving those, and then again, we will adjust the units accordingly. It depends upon the patient's meal, big meal, which one is the big meal, and the reading is high at which time, and again about the whole timing of meal. And someone has asked even about the timing and max doses of insulin. It depends if the patient is taking a light breakfast and the postprandial breakfast reading is not high and it is reaching the target, but she's taking a large meal, a lunch is very heavy or a dinner is very heavy. To begin with, we have to achieve target. So we can start with the lower side and we can adjust according to the patient's meals and according to the patient's meals timing and so on. It's really an adjusting thing.
Thank you. I think they were asking about regime like premix or basal bolus. Basal bolus is the ideal way of treating diabetes during pregnancy because that is more flexible. The other thing that we should all keep in mind is that even if you're using the short-acting analogs for bolus insulin, you have to inject it much earlier as compared to the non-pregnant people because there's a delayed absorption of insulin from the subcutaneous tissue during pregnancy, so like 15 to 20 minutes during first and second trimester, and maybe a little later, like 25 to 30 minutes in the third trimester. So that should be done. So Professor Haleema, Yasmin, would you like to give your expert comment?
Thank you very much, Dr. Aisha Sheikh. I must congratulate Pakistan Endocrine Society over this wonderful event, and I must congratulate for taking this initiative for having us all on board. The obstetricians, the Obstetrician Society, the SAFOG, all of us are ready to be partner just because of your resilience and your constant support for telling us that definitely we can do it. And your way forward by the way you presented was really wonderful, and I'm really excited to start all this work together. And my congratulations to the colleagues from other SAFOG regions, and also to Professor Ronald and the whole team of Pakistan Endocrine Society for holding this event so successfully. I'm not going to talk about the management and the exact part of managing gestational diabetes, but definitely you owe a great, great applause from our side. And thank you very much for having us as partners. We are definitely on board with you people, and this will definitely go ahead, especially if we involve the midwives and the nursing societies with us. Definitely we can bring in some change on this the volcano of gestational diabetes mellitus coming up in our nation due to poor nourishment and poor nutritional habits in our women. Thank you very much.
Thank you very much, Professor Haleema. And you have also been really helpful and cooperative for all those meetings that we were calling at the night times. And yes, for last many months we have been working. And finally, I'm really happy that we have come to this collaboration. And inshallah, we hopefully will improve care. So I think we have already passed the session's time. I'm really grateful to our speakers, moderator, and our panel of experts. And we'll be meeting soon again in the virtual world, or maybe in person when the pandemic ends. So take care. Thank you. Allah Hafiz and goodbye. Thank you very much.
Goodbye.
Thank you, Aisha.
Thank you.
Thank you, Professor Ronald. Thank you.
Thank you. Thank you very much.
Thank you
Bye-bye.
very much. Thank you, everybody. Bye.